Okay, welcome on board for the second session, and I hope you enjoyed the first one. Maybe Zoom will solve the issues, the technical issues actually we had last session. I'd like to encourage you to ask questions as I did last session, and about the language, please just notify me whenever you want me to convert to Arabic. Confidentiality is an important thing. The plan for today, we will have two calls. Each call will last for 40 minutes, and we can have a third one for questions maybe. For the first one, we will do a small revision for the last session, and we will continue with the rest of study types. For the second part, we will try to analyze the types of bias and the types of data. And for the third one, it will just be for your questions. I hope you have access to the Excel sheet for attendance, so please just put one beside your name whenever you attend any session. Those are two breezy presentations, so you can enter them even after the presentation. So I hope we are ready, and we can start. Actually, today I prepared the papers in order, so you can start with paper number 2. Okay. Do you have paper number 2? You can put thumbs in Zoom, and please just interact as we did with Skype. Okay, since I'm not getting any, okay, I got some thumbs. So I hope if anything went wrong, please just notify me and unmute yourself and just speak when you have a question, unless it is like able to be delayed, and then you can send it to the chat room. Okay, now for actually for this paper number 2, we will go directly to the tables as we did last time. And sorry, before we do that, I'd like to tell you that last time we read 2 case reports, 1 case series, and I believe those are really easy, so we don't have to repeat them. For them, we don't have any tables in the results, and if you have one, it will be reporting just data from one patient. As we remember, one table was for the quality of life for one patient before and after chemotherapy. The third type was cross-sectional studies. For these studies, we sometimes have some associations, but the most important thing that we go to the population at very single moment, and we ask everybody the same questionnaire. It's usually a questionnaire. Of course, sometimes we can like analyze reports, or we can analyze medical records, but if I'm going to the hospitals and I'm taking all the records and I'm assessing the consent forms, the informed consent for every patient, so it is a cross-sectional study because I'm not approaching them 2 times. So this is the most important thing about cross-sectional studies, and it has several types. After cross-sectional studies, we read 2 case control studies. For these studies, we have some cases. Those are diagnosed with some condition, whatever it is. And we have 1 group of controls, 2 groups, whatever the number is. And we have that from the very beginning. When I'm going to start, I need the group of controls and the group of cases, and I start analyzing them from the very beginning. Usually, when I have the condition, so I can't go further, okay? I have the pancreatic cancer. So what I'm going to do is to ask about the past. Did you take aspirin? Did you drink coffee? Did you smoke? And I ask about many exposures. The other way around is I go to some patients, some cohort. They can be patients, they can be the population of a city or anything, but it is a cohort, one cohort. And I ask them, are you exposed to smoking, to swimming? Do you play sports? What do you do? Okay. Sometimes we have half of them. Sometimes we have 20% of them. Sometimes we have 80%, and we don't have any control. I can't go to a cohort study and I tell them, can you please smoke, and the other part will not smoke, or I will give 20% an intervention, because when I'm intervening, it's not a cohort. Okay, for the cross-sectional, for the case control, and for the cohort studies, I'm just analyzing and observing. I'm not approaching them and making them do anything for me. So for the cohort study, I go to them, I have that population, I know that 20% of them are exposed to some kind of risk, and I can ask, what will this risk do in the future? So I will follow them after 1 month, after 1 year, after 10 years, and I can ask them, did you get diabetes? Did you get any cancer? What did you do? Okay, so I have no control. I have that population. It is homogeneous. I have classifications, but I didn't do these classifications. I'm following. Yeah, there are some exposures, but I'm not looking at them. I'm looking at the results. What conditions will I have? Okay, so we are done with these cohort studies and with the cross-sectional studies, but are all cohort studies the same? Not really. Some cohort studies, I go back in time and I take all the medical records for rheumatoid arthritis patients in my hospital, and I call them right now or in 1 month, and I ask them, how are you doing nowadays? So this is a cohort, but this is a retrospective cohort. What does it mean? I go back in time and I collect my cohorts in the past, and then I'm assessing it now. But I'm going forward, okay? Because the outcome is now. The outcome is not in the past. For the case control studies, I can go to the past to 2000 and I collect some cases of pancreatic cancer, and I can go call them, ask them, what did they do before 2000? What should this study be? It will be a case control study, okay? Because I'm going retrospectively. But if I'm asking them about their condition right now, it is a prospective study. I hope if any one of you go to WhatsApp and check if there is anybody missing, because I just see 17 people here, they were 20. So I think some of the participants are missing the connection, are losing the connection. So now we have those retrospective cohort and we have the case control studies. Now, are all cohort studies retrospective? Like, many of them are like this, but some of them are not. Some of them are prospective cohort studies, okay? So now we go to this study, study number 2, and I hope you just like tell me if everything is okay, because I'm not getting any feedback right now.
Okay, I have a question, please.
Yeah, please.
Our course you gave us, and I found it confusing to understand the difference between case control and retrospective cohort. I don't know why. They said that we can go back and collect the data and then analyze it in both case control and retrospective cohort. So what's the difference?
Okay, when I'm going to the data and I'm collecting my cohort, my participants, let's say, and I'm collecting all rheumatoid arthritis patients, okay? Just rheumatoid arthritis patients. And they have some classifications in them. Some of them did some kind of intervention, some of them did some kind of surgery. Let's say, let's suppose like this is the case. I'm taking a cohort of rheumatoid arthritis patients and I'm calling them now, asking them, how are you doing now? Okay, this is cohort. The other way, I go back to 2000. I find some rheumatoid arthritis patients, okay? And I collected them, and let's say rheumatoid arthritis is a rare disease or a rare complication. It's not like this, but if we say it is like this, okay? And I take another group who are controls, who are not having that disease. And I ask them, what did you do in the past? Have you been exposed to anything? Did you do anything to your joints? So this will be a case control study, okay? So case control, I ask about the past and I have two groups. Cohort, I have one group and I ask about the future. I hope this answers your question and we need to move on.
And what about the retro? Okay. No
Yeah,
problem.
please ask Zara. We can keep talking about it.
I'm confused with the retrospective cohort, not the
Okay,
normal
retrospective. Okay,
retrospective.
now we can mix. Okay, for example, I can go back and collect a cohort of rheumatoid arthritis patients, and I have some controls. Okay, and I ask them about the past. And after that, I want to call them now and ask them about their case today. Okay, so what I did is a retrospective case control study. Then I call them now and ask them about their current status. So this is a cross, sorry, not cross, it's a case control study and a retrospective cohort study. Okay, can it be in another way? Yes. I go back and I collect a group of SLE patients. And I call them and ask them now, what is your current status? What is this? We agree that this is a retrospective cohort. Okay, retrospective cohort. Then I call them 10 years later, okay, in 2030. And I ask them, what is your status in 2030? So what will it be? Retrospective cohort.
Okay.
Okay, so we can mix any of them, and we can mix cross-sectional studies, and it is easy. If I'm going to medical records and I'm collecting a cross-sectional study about them, then I go back or I go forward. So any of them can be mixed, but we need to understand the main types, and then we can mix whatever we want. Okay.
Ibrahim,
Okay.
just to clarify.
Thank you.
So the retrospective cohort, the difference is the beginning of my 0 point. It's in the past, and I will go prospectively. And the prospective cohort, I will start in the present, and it will go prospectively. This is what you were trying to...
Exactly, and I can mix them.
You can mix them?
Yes.
We can do So I will write that in my protocol. So it will be a retrospective cohort.
Exactly.
Can we do that?
Exactly. The prospective cohort, you should collect your cohort right now. Okay, you can't go back. You should start now in 2020 and collect your cohort till 2021. Okay, and then follow them for 1 year, 2 years, whatever you want. Okay, but if you are saying that I will collect those patients and I will collect some patients in the past who just presented to our hospital in the past, okay, then this is a retrospective, prospective cohort.
Okay.
Okay. Okay. Now we have that strange figure. Okay, its name is flow chart, and for this flow chart we have this. We have some attended both Tromso 4 and Tromso 6, and we don't know what is this. Participants reporting no MSC at baseline, and we keep going with the same method we used last time. Okay, just when you have any hint what is the study type, just tell me or send to the chat. Participants with data on MSC at follow-up. So we have this very important word, follow-up. Those with age less than 80, age more than 80, reporting no MSC.
Because we're following up the patient.
Sorry?
We're following them up, so it should be a cohort.
Exactly, it should be a cohort, okay, but is it retrospective or prospective?
Okay, they are saying study surveys from 1994, so it's a retro.
Okay, so yeah, it is solved. Now we can see here that men and women are divided. We have like very big cohort. Okay, the thing that characterize cohort studies that they are big because we need a huge amount of participants to see the outcomes. But for case control studies, they are usually few. Okay, the educational level, body mass index, physical activity. So what can we suggest they are doing? They are seeing what are the risk factors for MSC, and we don't know what is MSC. If you can see here, those who are reporting MSC, participants reporting no MSC, okay, then we are collecting the risk factors for MSC, and we don't know what MSC is. And they are comparing men and women. What we have here is odds ratio, and we will talk about it. This is a number for association between a risk factor and an outcome. Body mass index, and the numbers continue. And I don't want to go any further. I will go back and read the title, and the title is so easy: a prospective cohort study on risk factors of musculoskeletal complaints. So MSC, we know what MSC is right now. So we are done with study number 2. We will go to study number 2 again. We'll go to study number 3. If you agree, I will go like faster because we don't have a lot of time right now. What do we have here? We have enrollment, baseline measures, follow-up 6 months, follow-up 12 months. Okay, so do you agree it is the same? Here we have age, body weight, body height, and so on. Okay, here we can say that we have 2 groups. If you remember, in a case control study, we had that 2 columns, cases and controls, because we can't mix them. Here we just have the mean, and it's for everybody. Okay, if we go further to page number 8, okay. So it is the same. Yeah, it is the same here. Who is reporting back pain within 6 months? Who is reporting back pain within 12 months? And we are collecting the risk factors. Okay. Then what do we do? What are we doing with this with these cohort studies? We are taking that cohort. We are asking who gets low back pain or MSC, and we like see what risk factors were contributing to these outcomes. Okay, so now we are done with prospective cohort studies, and I will read the title: Risk Factors for Back Pain in Marines, a prospective cohort study. Okay, are you satisfied with cohort studies? Do you know all the types of cohort studies and how they manage their patients? Please just use the sums, because with sums I can like just have an overlook. I don't know if you can see the way to do sums. Okay, I see.
Ibrahim,
yes.
A question. So when we saw the flow chart here, okay?
Okay.
So we didn't know exactly if we're studying in the past or in the present. So how come you decided that it's a prospective study? So they can follow the patients for 6 months in the past or for 12 months in the past. So this flow chart from it, I will know it's a cohort, but I will never tell.
Actually, the key word here is the enrollment. I don't do enrollment for retrospective cohort studies, because the patients are in the hospitals, and usually we have them enrolled already. But when I want to do a prospective cohort study, I need to have their consent that I will ask you again 1 year later. Do you consent? Are you enrolled in my study? But for retrospective cohorts, it's usually I go back to the records, okay, and I call them now. But when I call them now, I ask them, you went to the hospital 1 year ago, and I want to ask you a question, but this is not counted as enrollment. Okay.
This is not enrollment. So when you're doing the enrollment, you will like modify or not modify. You will define your inclusion and exclusion criteria, and you do that in both types of studies, right? Retro and prospective.
Actually, it's like enrollment, but it's not named enrollment in these charts.
Okay. What we name it for the retrospective study?
It doesn't say that. If you remember that we have retrospective studies, and you can open them, and you can't actually find those flow charts. Usually, retrospective cohort. Usually, it's not like this is structured. Okay. For retrospective studies, we have those reports. I will search for enrollment. Okay.
Okay.
Let's see. No enrollment. I will go to the second retrospective cohort. But as I told you, it is like enrollment, but it's not said like I'm enrolling patient, because if I'm enrolling, this is a continuous process. I'm enrolling patient. Patients are coming, and I'm enrolling them. But for retrospective cohort, I collected a cohort of patients. Okay.
No need for consent at all?
Actually, for retrospective cohorts, we have their records, and usually when people like are admitted for Assad Hospital, for example, they consent that we are entering a university hospitals, and our records are okay if they are published. Okay, So we have their consent in university hospitals. Of course, sometimes we need to approach them again and just sign this letter. It's called in consent, but it's not like enrollment.
Okay, thank you.
You are so welcome. And no enroll in this. So yeah, okay, as we said before. Okay, now we have this. Can we just skip and go to RT1? I think this call will end in 9 or 8 minutes. So we will have 9 or 8 minutes, and Dr. Maya, you can't answer about this study. You know it. Okay, here we have this figure. This figure is saying first, second, and third year medical students. Some of them declined, and we have here a word saying randomization. And do we need any other clue? Okay, so
No, we don't need.
Okay, it's randomized. Then when I'm randomizing patients and I'm allocating them to different groups, then I'm intervening.
Yeah. So it's RCT.
Okay, so I'm intervening with professional-led training and peers-led training. Okay. If we go here, this is the process of the course, and we don't need to read about it. This is the process of practical assessment. Here we have the characteristics, and characteristics are fine for everybody. Okay, for characteristics here, can we have 2 groups or 1 group? Actually, the 2 ways are possible. Those are 1 group. I'll consider them 1 group because they're not divided according to my randomization. Okay, but I can report after randomization, the characteristics after randomization, and I can report before randomization, as we did here. Okay, here we have the results. For the results, the professional group, the peers group, and they are all classified. Here we have the first attempt, the second attempt, so we know that there is a follow-up. For randomized control trial, I do the intervention and I follow up. Okay, I think that is right. Okay, we will go back. Peers versus professional training for basic life support in Syria, a randomized control trial. Okay, do we have any question about randomized control trial? Okay, so we will go to paper number 7, RT2. Okay, for this paper, we will also go to the first table. Okay, as I said like 2 minutes ago, I will just minimize this. Okay, here we have a table with early hydrocortisone and a placebo. So, do we need any other clue? But we are comparing the number of cases in each group, the mean age, males and females. Okay, so this is the other way. As I told you, included. Exactly, Ahmed, you are so right. Okay, okay, here we reported them in another way. In the first study, we said that we have that group and the characteristics is like this. And as I told you, here we reported after randomization, or after we allocated them to different groups. Here we have different outcomes. Here we have this survival rate, okay? Whatever this chart is named, but it says that 40% of the patients were saved and they died after a while, or they had the complication. Here they are saying about the detection rates. The detection rate for a virus after the intervention, and we are comparing those two lines. If we go on here, we have plasma RNA concentration for that virus, and it is going down. Okay, so for this intervention, does that fit for a cohort study? Yes, that can fit for a cohort study. We are collecting data and we have outcomes, and the outcomes, for example, are exacerbations for epilepsy or SLE or whatever it is. So every time I count one person with this outcome, I will downregulate that line for 1%. So it can be for cohort studies, but since I have two different interventions, I don't believe that I will go and ask them who is taking hydrocortisone and who is taking another type of corticosteroids, because I usually give them. Okay, it can be, but usually when I have that intervention, I do a randomized control trial if I can do. But of course, if I'm a medical student and I don't have the opportunity to intervene in the decision, what should I do? I go to the specialist and he says, like, I need to decide and you can decide. So I can't do a randomized control trial, so I do a cohort study. The intervention is not decided by me, so I do a cohort study. So the title is, where is the title? The title is here, effect of early corticosteroid treatment on plasma coronavirus RNA concentration in adult patients. Okay, but this is not the COVID-19, it's an old study about SARS. Okay, so I hope we answered all questions about randomized control trial and cohort studies and all observational studies. And in the second call, we will move on to other types of studies. Okay, so please collect your questions and I will prepare answer in the second call. The second call will be in 10 minutes. I will send the link again to the group. Okay, so have a nice break. Just please remind me to record every time we call. Okay, we will move on. Data synthesis. Okay, we still don't have any results, and we come to the acknowledgement and references, and it is done. What is this paper? We have types of studies, and we have included studies. So it's a totally different paper. Please mute your mic, especially if you have children. Okay. Meta-analysis. Okay, meta-analysis is does have results. Okay, so we don't have results here. So it is a protocol. Okay, so sometimes we download a paper and we think this paper is really very good. We have 15 pages and it's really complex to read, but it's all about methods. Then what is this paper? This paper is just a protocol. Haloperidol for people with schizophrenia, but it's an intervention protocol. Sometimes we publish a protocol and it is a way to lower the amount of bias. So this paper is a systematic review. What is a systematic review? A systematic review is a review of the already published studies. Okay, when we say a review, it's a totally different type of studies. We have primary or original studies, and for those we have patients. From case reports to randomized control trials, we have patients, we have real people. But here we don't have real people. We have studies. We include studies, we exclude studies, but we don't have participants. We do these protocols and these systematic reviews and every kind of protocol of reviews from home. It's a bibliographical work. Okay, so if you do agree, I will close this. And now we will move to paper number 9. Okay, for this paper, I will minimize this. Okay, for this paper, we have internet addiction, a brief summary of research and practice. Do you have any clue what this paper is about? I will go to the results. We have introduction, classification, diagnostic criteria, and this is a new paper. We don't usually have diagnostic criteria in a paper. Then prevalence, reward, etiology. Okay, it seems like one of the lectures that are printed out, the lectures we usually study in our medical studies. Okay, so if we have something like this, okay, that summarizes everything about addiction to sugar or internet, I don't remember. Psychological approaches, so we have interventions to treat that addiction. What else do we have? Multimodal treatment, a program for treatment, conclusion, and references. What is this paper? We don't have any table, we don't have any section for results, we don't have any methods. We just have introduction, sections that summarize every aspect. We started with the prevalence, with the diagnostic criteria, then to the interventions, then a conclusion. So, what do you think this paper is about? What is the study design for this paper? Do you agree this is a review or an original paper? Okay, please chat, please just intervene, plus.
It's a review?
It's a review, but a special type of review, okay? So for reviews, we have two big types, okay? We have something like this that summarizes everything, and we can take another example, okay? Let's take this paper, paper number 10.
A systematic review?
Let's just take a look at this paper, and we will decide what type of reviews are those, okay? For this paper, we'll read the title, Potential Treatments for COVID-19, a narrative literature review, okay? Written by one person, okay? What does that mean? Literature review. Yes, actually, this is right. Okay, if we go through this paper, we have introduction, then we have methodology. We have some studies that are included, but they just use PubMed, Embase, Google Scholar, and we have very small methodology part. Then we have just the results, and we know that COVID-19 is really recent, and this paper is already received and published in January, actually received in January 2020, so it's received after days from the crisis of COVID-19 in China. So in days, in a matter of days, they searched everything. They have some clinical reports. They reported every paper, and every paper, if you can see, every paper is from 2020. So please just estimate how quick is research. All these papers were published, and the person who wrote this literature review reviewed every paper and published and conducted a full paper about them just in a matter of days. Okay? Case reports, he is talking about everything. Clinical reports, case reports, potential drugs, conclusion. Okay? And he has the references. Okay, now we have here something new, a small section for methodology. Actually, the most important difference between literature reviews and systematic reviews, and I hope you see me, because I don't want just to you to see the paper. So if you also see me, that would be really beneficial, because I usually use my hands more than my tongue. Okay, if you see me, please just put the thumb or something. The most important thing as a difference between literature reviews and systematic reviews is the methodology. Okay, when we have a methodology and a very structured methodology part, then it is a systematic review. Why? Because in a systematic review, it says it's systematic, manhajiyya. Then we have several steps. We have to go through them one by one to have the results. For literature review, it's not like we have a very structured methodology. We can't just have like a very small methodology. I searched that database and that database, and I got some papers and I published them. For literature reviews, I can judge that person and tell him that you just forgot to mention one paper, because he is saying it's a literature review, it's not a systematic review. Systematic reviews needs a lot of time. They need a big group, not one person, and it can't cover all aspects of that disease. For example, in the last paper, you see that they talked about everything, the prevalence, the interventions, and everything. But for systematic reviews, we focus on some outcomes. Here, we can focus on everything. We are not judged for our bias, because we can select the papers we want. But for systematic review, there are rules. We have rule number 1, rule number 2 for inclusion, for exclusion, and we can't cross them. Okay. For systematic reviews, we can't be like one person conducting a systematic review, because when we are assessing the papers for inclusion and exclusion, we do go to the papers, but not just one, 2 persons assess the paper, and when they agree, the paper is included. When they agree that the paper should be excluded, it's fine too. But when they disagree, we need another assessor. So at least we need 3 people to do a systematic review. Okay, I hope the difference between the 2 types of reviews is clear, and now we can have a look at a systematic review, a real systematic review. So we will open paper number 11. Okay. Sorry, I thought there is a question.
There's a question.
Ah, okay, thank you. Better power of evidence. Not really. It's totally the other way around. When I say that a systematic review is very structured, we have several people who are assessing the paper for inclusion and exclusion. We are analyzing everything. We are collecting all the studies, and we are including them depending on rules. Then this is very structured, and it is really higher in evidence. When we are talking about literature reviews, I can do a literature review. I can go to the papers about coronavirus and just collect some of them and do a literature review and publish my opinion. Okay, literature reviews, it's right that we collect some papers, but it's to report my view on these papers. It's not just about like telling people that that person said something, because he already said and published that, and they can go there and read it. But when I'm publishing my opinion, in addition to those, it is a literature review. Okay, so a literature review, those 2 types of the reviews actually, one is the highest, a systematic review is really high, on the top of the hierarchy of evidence-based medicine, and the literature review is the lowest. Okay, so the difference is really huge. If I have a case report, it's better than a literature review, unless this literature review is discussing a case report. Okay. Any cross-sectional study is better than a literature review, unless this literature review is reviewing some cross-sectional studies and so on. But we can't compare a literature review to a systematic review, okay? Because of course a literature review is lower in evidence than systematic review, okay? When do we do systematic reviews? When we have I forgot to tell you that RCTs are better than cohort studies. Why? In cohort studies, we are just observing. We are not 100% sure that the outcome is because of our intervention. But when I'm saying a randomized control trial, I'm saying that I have a collection of participants and I divide them randomly. What is the point of allocating them to different groups randomly? This is to make them both equal. Okay, so I have two groups of participants that are really equal, and if they are not equal, then my randomization is not good. And I do the intervention just to that group, so I'm sure that the outcome is related to my intervention, and this makes an RCT better than a cohort study. Okay, I have several RCTs about haloperidol discontinuation for people with schizophrenia. And these papers are saying discontinuation do harm to these patients. And some of the studies say that it is like, it's not harmful, it's useful. Okay, then what is the problem? There is a very big problem now. What should we do? We should do a systematic review. Why? If I do another RCT, it will contradict with other RCTs. Of course, it will like move the balance to one of the sides, but that's not the point. I don't want to lose money and just to make the balance go to one side. And in case I have two RCTs here and two RCTs here saying harmful and saying useful, and I have now 3 compared to 2, it's not a very big evidence. But if I go and do a systematic review, I collect all these studies and I say, according to rules, I will exclude those studies with low evidence, with low participants, with very few outcomes. And I will just take the very best studies of these studies and compare them and gather them together, merge them, and just give you one answer for your question. Isn't this better than doing another RCT? Yes. And since systematic reviews are usually based on RCTs, they come really high because each one of these systematic reviews include 2, 3, 4 randomized control trials, sometimes thousands of randomized control trials. So you can just estimate the amount of work we need to publish just one systematic review. It takes years, but days for literature reviews. Of course, I'm not talking about everything, but some of them are just published in days. Okay, I won't take about this because this is a summary of the full systematic review. And when you go to a systematic review, the systematic review is really huge. 38 pages, sometimes it's hundreds of pages. So here we have a methodology. And if you remember, this is really similar to the protocol of a systematic review. So we have the protocol, and then we have a section for the results. When we stop here, it's a protocol for a systematic review. When we continue, it's a full systematic review. Okay, here, this is interesting. Study flow diagram. It's similar to the flow chart. If you remember, we have some participants, we enrolled some of them. Here, we have 41 records, 3 studies, 3 records, 7 records. Then what are we including? We are including studies. Some studies come in, some studies are excluded, but we are working on a full studies, not single participants. Okay, we move on. Here we have something that, like, we have 5 studies. For each risk of bias, we have an assessment. A really low risk of bias, colored in green, high risk of bias, colored in red, and unclear risk of bias, colored in yellow. So we have that table in every systematic review because some of the exclusion criteria can be for the risk of bias. If I have this paper that has just one low risk of bias and everything else is unclear, I can exclude it. Okay, it's according to my rules. Okay, sometimes I include everything, sometimes I exclude those who have just one high risk of bias. Okay, if we go on, it's a discussion and we move on. Somebody said a word, and this word was meta-analysis. So what is meta-analysis? This is meta-analysis. Okay. A meta-analysis is when I have some papers that can be merged, I put them together and merge them. I won't go into details right now. We can give another session. Actually, it's not included in this course, but we can add a session to discuss this chart. We can see here 2 studies, the 2 lines, and we merge them in this shape. And this gives me an answer. Here, useful. Here, or look, here it says favors continuation. Here, favors discontinuation. Then, this systematic review answers one question: is discontinuation good or bad? But when I'm saying literature review, it discusses everything. Okay, just all these papers to just give me one answer to one simple question. Okay, and we have several meta-analysis. Okay, now we have that question. Does every systematic review need to have a meta-analysis? We open paper number 12, systematic review 2. Okay, this is also a systematic review, and I won't go into a lot of details. Methods, results, and we don't have any table, any figure, anything. Okay, does this count to you as a systematic review? Please just let me hear anything, because I feel really bored when I'm just speaking to the computer. Okay, I'll keep speaking. It is a systematic review. Why? Because
we can
very big
review without, we can have a systematic review without a meta-analysis, but we can't have a meta-analysis without systematic review.
Exactly. This is the simple sentence that answers my question. This systematic review, why is it a systematic review? Because it has a big method. It says that we went to several databases. We collected papers that include the keywords 1, 2, 3, 4, those keywords. We included them in a special criteria. We excluded some in a special criteria, and we merged them. Okay, when we say we merged them, then we have a meta-analysis. But sometimes I just get 2 papers that worth including. And those 2 papers are reporting different outcomes. One of them is saying that we have an odds ratio of 1, and one of them is saying that we have a likelihood ratio of 2. Okay, I can't merge a likelihood ratio with an odds ratio. Those are different outcomes. Those studies can be included, but I can't merge them. So what should I do? I can do a systematic review, but I report my results as a discussion. I say that this paper did that, this paper did that, and I can like favor one of the sides, but I can't say an accurate number. When I can say an accurate number is when I have the ability to do a meta-analysis. I hope this is clear. Okay, and now we will go to paper number 13. This paper is really important. I will go through it and I will read just the titles. We have introduction, we have methods, search strategy, selection criteria, data analysis and quality assessment. We have the results, epidemiology, screening tools, clinical examination, quantitative sensory testing, pain intensity. What is the link between everything I've talked about? They are all diagnostic outcomes. Here we have psychological assessments, measures designed to assess treatment efficacy, assessment of health-related quality of life, assessment of disability. Okay, they are all not just diagnostic, they diagnose and assess the patient around diagnosis. Okay, laboratory tests, microneurography. Okay, what is this? I don't want to see that. If you go into any one of these paragraphs, they will say, we recommend that you do blah, blah, and blah. We don't recommend that you take a skin biopsy. We don't recommend that you take the biopsy before clinical examination. We do recommend you take the biopsy when you have something on electromyography. We recommend you take a skin biopsy when you have a quality of life that is really reduced. Do you have any clue what this paper can be? The word that is mentioned in every sentence is we recommend. We recommend. So what should it be? Guideline, exactly. So a systematic review is really an option. But when I'm saying that we do not report studies, when you read this paper, you don't see that one study said that, one study said that. No, they are giving you a final opinion. Do that, don't do that. Follow these steps. Okay, this is guideline. What is the guideline based on? Here we have the guideline on neuropathic pain and assessments. And when you read these names, they should like summarize the very big heads in that area. So the guideline, in the guideline, those people gather, they collect the best evidence. Sometimes they have systematic reviews for skin biopsies. But for electromyography, they do not have systematic reviews. They just have randomized controlled trials. For nerve biopsies, they do not have anything. They just have case reports that are saying in special cases, nerve biopsy is necessary. So they summarize that and they give their impression. What should be done? What shouldn't be done? Okay? So, is that clear? This is how guidelines work, and this is how medicine works. Who had the authority to write guidelines? The best people in that field, okay? And they know themselves. Of course, we are not included. Okay, but sometimes we can like do guidelines for our patients, for our area, because when I'm saying a guideline, they assess several things. Sometimes they assess the economy of the places they are in, but most of the guidelines are published in Europe and in the United States, and there they have no care about the funds they must pay for an assessment. Okay, they need a better quality of life. But if we go back to Syria, sometimes we do not have that funds and we do not have that ability to order skin biopsy for everybody. So we can be more skeptical. We can like be more strict in recommending these interventions that are really expensive. Okay, I really like to go on with papers, but you already know the most important papers, okay? After the papers we discussed, if you have any difficulty in finding the methodology, the study type, the meaning of the numbers of any paper, please just discuss with us, and we can discuss that in more details. But I feel that we are fine with that. Please just tell me. We have still 7 minutes to go, and I suggest we leave the risk of bias and those things for a third call. Please just put a thumb if you agree that we have a third call this evening for 40 minutes. Okay, more thumbs, please. Okay, I feel that we have the ability to do another call this evening, so I will just take another paper and we will leave the risk of bias for the next call. Okay, this is one of your papers, the papers you say that they are really difficult, okay? And we won't read the title, we will go directly to the first table, and you will answer me and I won't answer anything, okay? You have that look? Please give me an answer. What is this study, just from this table? What?
Case control study.
Exactly. So we have cases, we have controls, we have different answers for those outcomes. If we go on, sorry.
UA.
Okay, you need the numbers. What is the meaning for these numbers? UA, unadjusted odds ratio. So it's an odds ratio, and we will talk about adjustment later, okay? When we have an outcome that can be contributed to by another factor. For example, age can contribute to mortality, even if both persons are have the same disease. If we have two people who have diabetes mellitus, so one of them is 70 years old and one of them is 20 years old, and I want to assess my intervention on mortality. Okay, that person who has a lot of years, who has a lot of years, who lived already 70 years, have higher risk of mortality than the young patient. So I can't just assess my intervention on those patients like equally. So I adjust. I have that percentage of mortality or probability of mortality for a younger patient and the probability of mortality for the older patient. And I adjust. I say that if any mortality rate increases in more than 20%, 20% here and 20% here, which is different, okay? I will say that it is positive. and I will count it in the odds ratio. This is adjustment, like taking those two together to adjust and then do the analysis. Okay, here we have the unadjusted odds ratio, and here we have the adjusted odds ratio and the confidence interval. And just please take notes of everything: adjustment, odds ratio, confidence interval, chi-square. This is a chi-square, which is a test. And we will talk about them all. We are not in a hurry. Okay, please, do you have any question about study types? Because we will like build our course on your understanding of these studies. Thank you, Ahmed. Okay. Please,
Thank you.
like, ask a question, intervene, interrupt me, because this is
Just
how we feel interactive. Yeah, please, Maya.
yeah. So for the systematic reviews, okay.
Mm-hmm. Yeah.
So if I will use your method to check if it's a systematic review or what. So you only check the paragraphs. We have methods, we have results, we have, this is it. But
Okay.
we have methodology and results in so many other types.
Mm-hmm. Actually, I'm not saying that when I read the systematic review, I just check those. But when I see that in the methods, they say types of studies, I understand directly that they are including studies. And when they are including studies, they are doing a systematic review directly.
Okay.
Okay.
But we another question. So if the systematic review does not involve any meta-analysis, okay, so it's still at the top.
It doesn't have.
It's still at the top of the hierarchy of evidence, okay.
Mm-hmm.
But
okay.
I can't like depend on the results, because it depends on the writer's way of like
assessing. Okay. Okay.
Maybe.
If I have two RCTs and I have a systematic review that gathered two RCTs and reported them, and this systematic review told me those two papers, what they are saying and what is the opinion of that person. Okay, but that opinion, when it is a systematic review, is better than his opinion when it is a literature review. So when I compare this paper to any of those RCTs, it's better.
Okay.
Okay, so see you in the next call in 10 minutes, and please have fun in your break.
Thank you.
You're so welcome.
Hey, doctor. So I have a question about the difference between meta-analysis and systematic reviews. I didn't quite get that.
Okay, I can do a systematic review when I go to every evidence that is available about something. Okay, I ask a PubMed what is available about the benefits of haloperidol for schizophrenia. Give me everything. I go to Google Scholar, I go to Medline, I go to Embase, I go to all these databases, I collect every paper. Okay, now I have every paper. I read them, I assess these papers, what should be included, what should be excluded. Okay, now I have everything. The included papers, here I have two options. Those included papers can't be merged. They are heterogeneous. They are conducting their studies on different age groups. They are reporting different outcomes. They are really heterogeneous. When the papers are really heterogeneous, I can't merge them. Okay? Meta-analysis means merging numbers. Okay, so for a systematic review, I've done a systematic review and I've got every paper. But did I do a meta-analysis? No, I didn't. But when the papers are homogeneous, I can merge 2, 3 of them. Okay, then I have a meta-analysis which is better.
Thank you.
You're so welcome. Okay, now if you see my screen and I feel that we are enough, but we are losing people as we progress through the sessions, we are losing people. Okay, now I'm sorry, this is an old lecture, but I felt that I really did it really good. And since you are able to view my screen, I shouldn't do that to you. Or maybe do this. I don't know why I made you see my screen. See yourself, I mean. Okay, here we will go to assessing risk of bias. Okay, what is bias? It's deviation from truth. How can I deviate? Anything that makes me go from here's the truth and I'm going here, here, or I'm going everywhere, everything is bias. Okay, bias has more to do with internal validity. What does that mean? What is internal validity and what is external validity? Actually, internal validity, when I'm talking about this paper, is it good? Is it really controlled? And does it have any problem inside this paper? And when I'm talking about external validity, I'm talking about like, if I take this paper and the results that I have from this paper and I go to my patients, does it fit? This is external validity. It's about generalizability. The ability to generalize the outcomes of this study for my population, for my patients. But internal validity, is this paper good in itself? Okay, so bias is a problem of this paper. It's not a problem of taking the outcomes. Okay, so this is a very important point. What are the problems? I need to go to this red square in the center. I have two measures, accuracy and precision.
Yeah. Can you repeat the internal validity?
Internal validity. I feel like Lena is talking, right?
Lena, okay. From my...
Okay. Internal validity is, I have a paper. I'm reading this paper. Is there any problem in this paper? Problems can be like the control is not really good for my cases. The problem can be like my outcomes are not relevant to the thing I'm talking about. I'm talking about mortality and my outcomes is about the WBCs. So it's not relevant. So there are problems inside the paper. This paper is not good. This is internal validity. But external validity, this paper can be really good and really controlled and everything is perfect. But it can't count to my patients. It doesn't fit. Yeah. Okay?
Okay.
Okay. So now for bias, what does bias do? Bias is taking those answers from here to the side. What does that mean? That means that the accuracy will go down, but the precision will stay the same. What is the precision? Is when I like put 4 points, I have them in a very small area. This is high precision, low precision, low precision. Okay, what is accuracy? Accuracy is like hitting the target, okay? Getting what I want to get, okay? So bias make us deviate from the center of the circle. But if I have any problem with, it's not like bias, it's like about randomization. It's about like my assessment is not accurate. I'm not dealing with every patient the same. This will make the data like distribute, and I won't get a very high precision. Okay, so bias make a systematic error. What does systematic error mean? Deviation for every hit to the same direction. But when I have those points like distributing all over the place, so I'm not having systematic error, I'm having random error. The problem can't be bias because I can't like calculate bias. I have bias in including patients, so I know where my results will go. I bring them to the center. But if I don't know, they are all distributing all over the place, so I don't have bias. I have something random, and the problem here is not systematic error. It's called random error. Okay, I hope this is fine, and we can move on. Those are the same. Okay, a bias can bias every step of our study. What does that mean? If you can see here, right, I did a mistake in the first session. I said attrition bias. Well, I meant performance bias, and I'm actually really sorry for that because I didn't correct it and right after this session. Okay, we will talk about the types of bias. I'm allocating, I'm bringing patients in my study, I'm enrolling. What bias can I do? Selection bias. I'm taking everybody from Al-Masa Street. I'm taking everybody from a very small school. I'm taking just the rich participants. This is all selection bias. Okay, but my study can be around rich people. So in this way, it can't be, it's not bias, it's not counted as bias. But when I'm saying that my sample is representative of all the population in Damascus, and I'm just enrolling the rich people, then this is selection bias. So I need to compare selection bias to my inclusion criteria. Okay, now I have exposure. In cohort, we have exposure, and I don't control that, or intervention. When I'm controlling that, what bias can we have? Performance bias. And how does it happen? Like for those who I'm doing, I'm giving the placebo, I don't care a lot. I don't give them a lot of care. I put them in normal rooms. I put them like in dormitories, or like I don't give them a lot of care. But for those who had the intervention I want, okay, I take care of them. I put them in the ICU. I make the doctors check on them, every day. So this is performance bias, because I'm not now I'm not comparing the intervention to placebo. I'm comparing the whole condition, and this is performance bias. What is attrition bias? Okay, we can go. Okay, now we have attrition bias, detection bias, and reporting bias. Yes, please ask.
Ibrahim, performance bias has some other name, right?
Everything of those have really different names, and we will talk about this. So I will move to the next slide.
Don't. I like this slide.
Okay, so we will go back to it. Attrition bias is, I have my patients and I don't have any performance bias. I dealt with them the same, but I lost every participant in the control group, and I still have the patients in the cases group. Then there is something wrong. Those in the control group, they are feeling that they're not having good care and they are running away. So this is attrition bias. losing patients. And this is my mistake. I said that attrition bias is performance bias, and yeah, I really mixed them. I'm sorry about that. What is detection bias? I did them with the same way, and I don't have loss of participants, but when I check the mass in their abdomen, I give more care when I'm detecting the mass for those who received the intervention. But when I search for these masses for people with placebo intervention, I don't care because I know that it is not going to be changed, okay? So this is detection bias.
Why isn't it a performance bias?
Performance bias is with the intervention, okay? I'm giving the
Okay.
intervention in different ways, but detection bias, I'm doing the assessment in different ways.
Okay.
Okay. Reporting bias is I have all the results and I just report the positive results. And for the negative results, I just discard them. And this is really a big issue. Okay, we will move to discuss each one of these bias alone. Selection bias. I bring everybody with the same characteristics, and I say that those patients are really random and they are selected randomly from, and they represent the population. They are not. This is selection bias. Okay, as Maya said, we have different kinds of selection bias. For example, I got a really target population and they are random sample from everybody in the population. But what I did is, when I want to do the allocation means distributing those participants to two groups, one of them with intervention and one of them with the placebo. I did that. Is that good? Yes, actually, that is good because I feel like the two groups are really similar. But what is this? This is called allocation bias. Yeah, the whole target group I gathered, the cohort group, is representative of the population, but when I allocated them to different arms, I allocated them in a wrong way, okay? I didn't allocate them in a random way. So this is allocation bias. This is a part of selection bias. And here we are done with selection bias. Questions?
So selection bias has a sub-bias thing.
Each one of those will have different different types, okay? So those are the main types, but for example, we have funding bias. If I'm funded by a company and I want the results to be like consistent with the aims of this company, this is funding bias, okay? There are hundreds of types of bias, okay? So I'm just discussing the main types and there are a lot more.
Okay.
Okay, characteristics is a really important thing. Performance bias. When I go to these participants and I don't want to do performance bias, can I do that? If I know those people are getting the intervention and the other are not getting the intervention, can I like
I should do blinding, so I won't do that.
Exactly, I should be blinded. So the solution for this is when I go to them, I don't know if those participants are receiving the intervention or the the placebo. This way, I won't perform any performance bias. Okay, not like this. Can I always do that? Do the blinding? It's not applicable in every situation. For example, if some of them are receiving surgery and some of them are not receiving surgery. I can't be blinded to that. Okay, if some of them are receiving warfarin and warfarin has a lot of side effects, I can't go to them and I tell them that take care, you are taking a blood thinner that might be warfarin and you should take care of that and you should report that to every time you go to the emergency room. Some studies can't be blinded. Sometimes it can be blinded from the side of the participants. Of course, if I'm going to undergo surgery, I shouldn't be blinded. You can't go inside my abdomen and just tell me that maybe we have 50% chance of taking the spleen out. That is not applicable, okay? So blinding is not applicable for every study, but when it is applicable, it's better to do it. If somebody has any question. Okay, attrition bias. We have different kinds of data loss. How? Not data loss, but participants loss. Sometimes they withdraw. Some of my participants just withdraw because of side effects. Some of them because I'm not treating them very well. Okay, incomplete assessment. They do not have time. They traveled. Okay, for every study, we will have loss of follow-up for some participants. But when can this be a problem? We have those participants. We have those missing data. Okay, when can this be a problem? When I have two groups, and this group is the control group, and this group is the intervention group. For the intervention, I have
if they're equal, so they will affect my data analysis.
100%. For the control group, I don't have as many loss of follow-up cases as in the intervention group. What can I conclude? That my intervention does do something. It might have killed some patients, might have given side effects to those patients. I don't know. I need to control for that. Okay.
Okay, there's a question about the last idea about the blinding.
Blinding, yeah. No, if the patients are taking placebo or the medication, we can consider it as bias. Yes, of course. If I'm telling you, Ola, that you are going to take a placebo, thank you for your contribution in my study, but you are going to take a placebo. Will you feel the same when I'm telling you that you are going to take a very promising drug? You might be treated just by my quote that I'm saying that you are taking placebo or you are
The psychological
very
effect.
promising. Yeah. Okay. So yes. And the other type is the placebo effect. If I'm not saying that you are receiving placebo, you might improve. And if you improve and you are not receiving any drug, then this is called a placebo effect. You are treated without a drug.
So there is also, Ibrahim, the nocebo effect. So it's opposite to placebo effect, right? So
exactly. So those are so detailed. I'm really sorry, Lena. I need to run because I don't know if you will welcome a fourth call. Detection bias. Okay, here is somebody who has treated with a promising drug. From his point of view, I think this drug is really good, and I will like inspect to get the effect of this drug. Yeah, the mass like has shrinked for 1 millimeter, and I will detect that with my palpitation. So that's not good. But when I'm saying that, yeah, the mass is reduced even in placebo patients, then no, I'm not seeing that. This is detection bias, and how can it be solved? With blinding, as we said before. Publication bias, it has several steps, and in every step we have some kind of publication bias. How can it be? I'm an author and I have some negative results, but for the negative results, I won't share them with anybody. I'll just publish the positive results. This is publication bias. I sent my article to the journal and they refused it. And I decided just not to go for further journals. So this is publication bias. Those are the articles, and they go through the author's beliefs, the word restrictions, the editorial approval, the peer review, and then we have those published reports. Okay, sometimes we are excluding really bad articles, but sometimes we are excluding useful articles. Okay, this is publication or reporting bias. Publication bias is the same as reporting bias. Okay, for assessing the risk of bias, we have different tools, a lot of tools actually. But
okay, just 1 second.
Yeah, please.
How can I, if the author didn't publish the negative results, how can I know that? Okay, how can I
when I'm doing a systematic review, with Cochrane, there is a step that Cochrane goes to every registrar for clinical trials. They ask them, has anybody registered a protocol for a study, for a clinical study, without publishing the data? They say like, yes, we have 10 studies, but we have just 5 published articles. Then we have 5 studies that weren't published. Then we have publication bias. We go to them, we ask them, why didn't you publish? They say, one of them say that my results were negative. One of them says that I'm not free to write the protocol, the results anymore. One of them says that the funding went down and I don't have any funds to complete my study. All of those are counted as publication bias. Okay, so when I'm doing a systematic review, I should take every article or every possible report of any data, even if it's not published. Okay.
Okay.
Perfect.
Thank you.
So, what are the types of data? We are working here. We are working on data. Okay, we can learn a lot about study designs, types of bias, and everything. But the main objective of this course is types of data. Okay. Well, what are the data? What are the numbers? When I'm saying that I have a variable, what is a variable and what is an observation? A variable is gender. Gender is a variable. For each observation, I have 2 options, male, female, and sometimes more. Another variable is age. We have all years, and we have observations. Each observation will have a different age. A variable can be drinking water, drinking or not drinking. A variable can be the amount of water drunk. And the observations are the cases, okay? So, those are data. Data comes usually as tables. And that's why we will need Excel. For data, we use Excel, Access, those programs. Are all variables the same? Not. They're not. First, we have simple data, like dichotomous, like yes, no, male, female, something, something else. Okay, we have more, for example, nominal, 4 types. We have ordinal, 4 types, but they are ordered. We have counts, like long normal numbers. Continuous, we can have like 1.5. We can have 2.2. Time to event, we include the time again. Okay. Increasing.
Ibrahim, can you emphasize this slide, because it's like for me it's complicated. Can you repeat it, please?
We will talk about this slide till the end of the call. Don't worry, Maya.
Oh.
From dichotomous, I just have 2 options, so it's so simple. But when I go to including time in my variable, it's really complex, and this is why the hierarchy is like this. I have less data, more, till I have time, and this is really a high amount of data. If I have the dichotomous data, if I have drinking water or not drinking water, can I move to continuous? I collected yes and no. After I collected yes and no, can I get a number? No. But if I get a number, if I ask patients how much water do you drink, and I have 10 liters, 11 liters, and I put a cutoff, I can move from the numbers to yes and no. Okay? Like I consider those who drink more than 2 liters per day as drinkers of water, and those who drink less than 2 liters per day as non-drinkers of water. So I can move from the big amount of data to dichotomous, to similar types of data, but I can move in another way. And you will understand that from the next slide. For dichotomous data, we have 2 types. No simpler way for the data. Okay, I'm really sorry. I just want to turn on the light. Yeah. Dichotomous data is really simple. Pregnant, non-pregnant. Nominal, categorical. It is the same. Nominal or categorical is the same. We have 4 types, 5 types, 10 types, whatever it is. Okay? For those, what do we report? I report frequencies. 50% of my participants are doctors. 90% are admins. Something like this, but I can say the mean of my population is doctors. Means are not for nominal or categorical data. Okay, I can't say the median is a nurse. Okay, a median should be a number. Okay, so if this is fine, this is better. Of course, who did that? Okay, someone is drawing here. If I have, I did say that I can move from a higher level to a lower level. I have here 4 types, and I can move to dichotomous. How? I will count nurses and doctors as health workers, and everything else as non-health workers. So I can move back, but I can't move forward. And what comes after that? Ordinal data. For ordinal data, I have 5 categories, but those 5 categories are ordered. Okay. Sad, very sad. From the other way, moderate, neutral, happy, very happy. Okay. Those are ordered. Okay. I can move and say that those are happy and those are not happy. Okay, I can move to make them dichotomous, but I can't say that We have a satisfied person, and this person is twice the person who is dissatisfied, because this counts as 4 and that one counts as 2. Okay, they are ordered, but the ranges between them
Unmeasurable.
are unmeasurable. Exactly. So we have a neutral, and we know that satisfied is better, and dissatisfied is worse, but we don't know if dissatisfied is really as far from neutral as satisfied. Okay, they are ordered, but they are not like distributed in equal decimals. What else can we have? Counts. I was bitten 3 times, 4 times. I wasn't bitten at all. Okay, for these counts, we have more data than satisfied and unsatisfied and so on. Why? Because it can be neutral. I can have one person who was bitten 100 times, okay? And I have no bites at all, okay? And I can say that that person who was bitten 100 times was bitten 50 times more than that person who was bitten 2 times, right? So is everything okay till here? Please just put something.
Yes.
Yes, perfect. How many people do we have? A lot of people. Okay. I see more thumbs, less people when we move on. Okay. Can I move from this data to dichotomous? Yes. I can say those who are not bitten will go in one category and everybody else will go in another category. I can say that one category is 0, one category is from 1 to 10, and one category is more than 10. Okay? So I can move back, but I can't move forward. If I have bitten, not bitten, I can't, after I collect the data, I can say that, those people are bitten 100 times, 10 times, and so on. Okay? But if I have the numbers, I can go back. We will move on. Okay, now we have continuous data. What is the meaning of continuous? I can have decimals and I can have fractions. How can it be like this? Okay, for example, the degree of temperature. Okay, the temperature. I can have 30.2. I can have 70, not 70, 27.3. Okay, this is continuous. But there is something here. It's continuous, but interval scale. What does that mean? If I say that August is hot and the temperature in August is 40 Celsius degrees. But in April is really cold and the temperature there is 20 Celsius degrees. Can I say that August is twice as hot as April? Please just answer me. Anybody
Yes.
can unmute. Actually, I can't say that August is twice as hot as April. Why? Because the 0 is not an accurate 0. It's not a real 0. If we have the 0 Celsius degree, and I go like 10 is half as hot as 20, it's not like this, okay? I remember that in chemistry, we had that real 0 in a different scale. We need to like do -200 or -290, as I remember. الصفر المطلق. So I don't know how they got there, but we know that our zero for our Celsius degree is not a real zero. Okay, it's just continuous, and we have degrees. We have Celsius degrees, but those degrees can't be like, it can't be a ratio. Those are twice are those and those. Okay, but the intervals are the same. Okay, please tell me if this is clear.
Yeah, okay.
Okay, so we will move on. What else can we have? If we have those degrees that are equal and the zero is a real zero, now I can make ratios like this. If I have a person who is 100 centimeters tall and another person who is 50 centimeters tall, then this person is twice as high as the other person, okay? Because the zero is like, we don't have a person, but we have a zero for height, okay? For example, for time, we have 0 seconds. For internet speed, of course, we have 0 megabytes per second. For speed, for acceleration, we have zeros. 0 speed means the car is not moving. 0 acceleration means the speed is not going up or down. Okay, so for those continuous scales, we have two types. If the zero is a real zero, we have continuous
ratios
data. But if the zero is not the real one, we have continuous interval scale. It means we have decimals, we have those small bars that are equal, but they can't be ratio. Okay, is that really clear?
It is.
Oh, thank you. Okay, and the last addition we can do is the addition of time. Okay, we have a scale, a continuous, not a continuous actually. We have an ordinal scale for headache. But what I can add is the time. For example, I have some patients and I treated them for migraine. I wait till they have an episode of migraine. Okay, so somebody have, somebody has, somebody doesn't have. Okay, and those patients are treated. They do not have any exacerbations or any attacks of migraine till the end of the study. Okay, and this is the highest level of data I can reach. Do you think that we can add any more data to our scales, to our questionnaires, to our assessments? Those are actually all the types of data, and we don't have more. We are going to work on those. So please, let's open up a discussion and talk about what we taught today. Is the types of data really clear? Because they need to be like 100% clear in order to move on.
For me, still not clear, so I guess I need to read these slides alone and we can discuss them alone to not waste others' time, okay? But they are not so clear. And if you have any like other resource to clarify them, I will really appreciate that, sharing it, okay?
Yeah, I will do.
Thank
you. Just any other question?
Please, but can I have another example about data where there's no zero?
No.
Except for
This
the
is the only
temperature.
example I know. I think I can get another example, but maybe 2 examples, not more. Okay.
Okay.
Okay. Any other question?
No, not for me.
Okay. I will do something. I will just turn off the screen, and I will talk about posture. So just 1 minute. Okay. Well, we have different types of data. The simplest way, I go to you, I ask you, are you satisfied with our course or not? I have either 1 or 2 of 2 options, okay? I don't have any more data. This is the simplest way. I can come to you and ask you, are you a doctor, a dentist, or a pharmacist? Those are 3. I can't say that this is a dichotomous variable. This variable is called categorical. Okay? 3 types, then categorical. 4 types, 10 types, categorical, still categorical. Okay. I can come to you and ask you a better question. Are you happy? Really happy? Neutral? Sad? Really sad?
Ordinal.
Exactly, ordinal. Do you drink a lot of water? Do you drink good amount of water? Do you drink a neutral amount of water? Okay, this is also ordinal. Okay.
Yeah.
If I'm coming to you and I ask you how many liters of water do you drink?
Interval data.
Sorry, Yusra, can you repeat it?
Interval data.
Continuous, you mean?
It's exactly, it's interval, because what do we have? We have a count, okay? 1 liter, 2 liters. So, but is it continuous? It's not, because if
No.
I'm asking you how many liters, you can't say 1.5. My options would be 1, 2, 3, and you have to round up or round down to the nearest number. Okay? When I'm saying those, when I have neutral numbers, then I have less amount of data. Those are interval data. Okay? Normal numbers. Okay, I can come to you and ask you, how much water do you drink per day? You can say 2 liters and a half. You can say 3.2 liters and so on. Okay, this is continuous data because you can put that decimal.
Fractions.
Fractions, exactly. Okay, this is a very high level of data. Okay, I can give another example of continuous but interval, not ratio data, and I will try to do that and send it to you. But if we move on, what can I add is time. And the example of migraine treatment, the example of any, for example, the example of mortality. I'm treating to prohibit mortality, to make the fatality of this disease lower, and I can see if those patients are dying or not. Okay, so those are the types of data, and I will try to answer your question, Nawal. So, any question? Kelvin scale. Okay, perfect. This is another, but this is also temperature. Up or Kelvin is the one for the real zero. I don't know. Okay, I'm really sorry for that.
Ahmed is asking if it is wait a second. So same variable can vary depending on how I measure the variable.
Exactly. But I can't say they are the same variable. The variable is defined in my study. So we have water. Water is not a variable. But if I'm saying I will assess water in one of my methods, it will move on to be a variable. Okay. So water is not a variable, but when I put it inside my study, I need to put it in a special way to make it a variable.
And I choose the way I am going to measure that variable, if it's going to be dichotomous, or anything else.
Exactly. Nawara, I got one of the examples I remember. Quality of life. For quality of life, we have a scale, and it is continuous. Okay, continuous because we have 2.5 quality of life, 3.5, 10.5, whatever it is. But can I say that the person who has zero quality of life, he doesn't have quality of life at all?
Not really.
Okay, so are you satisfied with my example?
Yeah.
No,
Kind
thank
of.
you. Anything else?
There's something unclear, but wait, I'm asking, what is it? Okay, the event time data is not clear for her.
Event time, okay. We have time. I can ask you, how many hours do you spend watching TV? And I can ask you, how much do you spend watching TV? How long? It can be normal numbers. It can be continuous. You say like 2.5 hours, 2 hours, 30 minutes, anything. Okay. And I can ask you, I will do an intervention to make you reduce your attendance for TV programs. So I will do the intervention, and then I will ask you. I will call you every day. Ask you, have you watched any TV today? You say no. Next day I call. Yeah, I watched. Then my intervention wasn't successful on the second day. I call Ahmed and I ask him, did you watch any TV today? He says, yes, I did. So from the first day, it wasn't successful. I call Maruf and I ask him on the 10th day, have you watched any TV in the last 10 days? He says, no. This is the addition. I have numbers, but I have something else. Okay, I have that. I can't say that Maruf that doesn't watch TV, but because on the 11th day he can attend any TV program. Okay, so this is the problem. This is the addition. We have time. We have the probability of doing it after the end of our assessment. Okay, does that answer your question? Rama, thank you so much. Okay, any other? Thank you so much, Ahmed. Any other question? Have a nice evening. Yeah, please. Yeah.
Last question. can ratio data be also continuous or something?
Of course it can be. It can be continuous and we add time. Yeah, that doesn't matter. So have a nice evening. Yeah, please.
I just want to make sure that I'm getting this correctly. So the time data can be any type of data, like dichotomous or whatsoever, plus the time, right? Like
I'm sorry, can you repeat your question?
So the time data, that can be any type of data plus the time element, like dichotomous plus time, watching TV, yes, no, plus time.
But actually I can't say dichotomous with time, because when I'm saying dichotomous, it means like yes or no. If I'm saying any type of normal continuous data, yeah, it can be. You are right. But in categorical, it can't be, because those who didn't receive any, who didn't watch any TV, can be counted as a category, and those who attended for 3 hours and those who attended for 10 hours. Okay, so I don't feel that we can use time for categorical or dichotomous data, but for the numeric outcomes, yes, we can add time.
Okay. Okay, thanks.
Thank you for your question, and thank you all for your attendance. And I'm sorry for the third session. And I will record everything. Everything is already recorded, and when it is converted, I will put it on YouTube or maybe a Facebook group. We can decide on that. And have a nice evening, and goodbye.